Hello there. Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. Welcome back to the podcast. Today, we wanted to address the ongoing issue of the LA wildfires and all of the families that have been affected by them. It's been an absolute devastation. We've seen families lose everything, to some things, to their friends losing things. And so vicariously, you experience that trauma. The entire community as a whole has been distraught by this. The biggest thing about the wildfires was just how quickly it spread. I think that was shocking. I remember hearing some things about it that morning and, just putting it off, doing some work. And then a couple hours later, it's like evacuation orders, almost like a tsunami. It just took over and you're not having a second to think. You just do the next thing.
And I think that we've been transparent about the fact that we live in Los Angeles. So this is obviously relevant to us. Unfortunately, things like this happen all the time, all over the place. So this is one example that is very relevant to the two of us. And I think spurred our interest in talking more in depth about this because it's such a helpless feeling when something like this happens, when your world shifts in such a sudden and profound way. And so what can you do about that to take care of yourself, whether it's a wildfire, an earthquake, pandemic,
Yeah.
no matter what it is that causes these sorts of shifts. The good news is there is the playbook, there are guidelines in how to step forward and take care of yourself and take those next steps so that you don't feel like you're having to make it up for the first time. But yeah, I think for context, I didn't even realize it got this big, but I was looking it up. But the wildfires apparently burned 50,000 acres, which is double what I thought it was. So there is a field of disaster psychiatry that looks into more the public health, taking care of populations who are going through this. But we're mostly going to be talking about how those impact an individual person, as opposed to the idea of rebuilding a community, of schooling, of what to do from a job organizational standpoint. This is really how it impacts a person or a family. So what is a disaster? Technically, a disaster is defined as a community-wide event resulting in collective trauma and substantial loss. As I say that out loud, I'm recognizing that I've already used the word trauma in two different ways. So I think it's worth talking a little bit about trauma too. When I say trauma, I typically mean a traumatic exposure. So a big shift in your expectations that causes a rethinking of what's safe, what's not, that can have a huge impact on you and how you see your world. The response to that, like PTSD, is more of a specific term and is a little bit different from the colloquial understanding of the word trauma. And unless I'm very specific about it, usually we'll be talking about traumatic exposure. We're not trying to add that extra weight to it.
And maybe just to dial back a little bit, we could talk about the normal response to trauma, because that's kind of the big question is my kid going to have PTSD from this? Am I going to have depression because of this event? So usually following a disastrous situation, there are strong emotional responses that are expected. This doesn't necessarily mean that something is wrong and something psychiatric is going on. In fact, Viktor Frankl, who wrote Man's Search for Meaning, he said that an abnormal reaction to an abnormal situation is a normal behavior. So this is totally abnormal. So of course you're going to have an abnormal reaction. Maybe your crying is bigger and louder than ever before. Maybe you're having these hysterical moments where you're screaming and throwing things and having this reaction that's not normal for you. And that's actually normal for a certain period of time. the timing is one big factor, not the only factor, but a lot of these things, if they persist for more than a month, then you want to look into professional help. So the immediate traumatic condition that you can get is acute stress disorder. These are symptoms of severe anxiety, dissociation, flashbacks, nightmares, difficulty sleeping, poor concentration, hypervigilance, avoiding or isolating from social interactions. But this lasts less than a month. And so that month mark is kind of what we use. And then if it persists longer than that, we start to consider PTSD, post-traumatic stress disorder. This is specifically characterized by 4 different aspects. So first, there's the intrusive reactions. So you have flashbacks and nightmares, these thoughts that come in and they won't leave you alone. Then there is the affective component. So you have persistently low mood, you feel persistently depressed. And then there's also a cognitive component, which I don't think people really talk about, which is that you can't complete your tasks, can't focus. You are easily distracted. You can't make decisions as well. So there's a cognitive executive function component that will decrease your daily functioning. And of course, the last part is that there's a 1-month timeline for this.
I think we've both seen people who come in after a trauma, but maybe misidentify or mischaracterize these symptoms. I've done a ton of ADHD evaluations that actually turn out to be trauma from a traumatic exposure and is more correctly defined as PTSD or major depressive disorder, that only after it comes out through the evaluation do you find out that it's a response to a trauma. It's not your mood having a mind of its own. So this can look like a lot of different things depending on how someone reacts. And someone can have a preponderance of one system set. They may have a lot of cognitive symptoms, but really not that many intrusive symptoms that they're consciously aware of. And so it can look different in different people.
Right. I think this is why it's so important to have a full evaluation. I would really emphasize going to someone who is open to different psychiatric conditions and have an understanding of them, because if you go to a niche person like the ADHD person or the trauma person or the anxiety person, that's all great if you are fairly certain that that diagnosis reflects your true condition. But if you're not sure, then going to a psychiatrist, child psychiatrist is so important, because you have to rule out other things. And if you're going down a path that's off, it can do harm. Sometimes stimulants can worsen anxiety. Sometimes you get put on a mood stabilizer when a lot of it was trauma, or you get put on an antipsychotic and a lot of it was trauma. And so I think it's really important to have a full psychiatric evaluation.
Yep. Could not have said it better. The short way I sometimes say that to trainees is, if you see somebody who's only got a hammer, you're going to look like a nail. If someone, they're really good at diagnosing and treating ADHD, but don't know anything about anything else, everyone who walks in that office is going to have ADHD. So you want to start with the evaluation and then move on to treatment.
Right.
There are specific evidence-based factors that can negatively influence mental health outcomes after traumatic exposure. So if somebody has pre-existing trauma, one way to think about that, which turns out not to be correct, is if you get a cut, right? Your body reacts to that cut and creates a scar so that you're less likely to experience injury in that same area. The scar is protective, right? That's not quite how it works with trauma. If you have one trauma, you're actually more likely to have a traumatic response to a second trauma. So it's not that you get that sort of scarification. It's quite the opposite. And people who have cardiorespiratory conditions, heart failure, high blood pressure, asthma, anything that is not great with the stress response, anything that we as physicians would say, you need to take it easy, you need to relax, is not good when you're going through a traumatic exposure and can make it much harder to bounce back. We do know that people who are more vulnerable to traumatic exposures are children. Children have a lot of life in front of them. And so if something big comes in and shifts how they see their world, that can have a long-lasting impact. And so I don't want to make it sound like that puts so much more emphasis on having the correct response. I don't want to increase anxiety around that, but it is something to watch out for and get ahead of. And people with fewer resources, so people who live in rural communities, who are more isolated, who have fewer social supports, who have lower income, who might be disadvantaged because of their legal status, their minority status. Anything that you would think of that makes you vulnerable in one way is doubly more so during a traumatic exposure. One
Yeah.
other really substantial risk factor is substance use, and that can be for a couple of reasons. One is that in general, people who use substances are using them because they may not have the best coping skills outside of that. And so if you take somebody who is already having trouble with coping and then you introduce this big traumatic exposure, that's sort of a double hit. Not only are they going through something, but they don't have the skills to cope with it. And they may even dive deeper into substance use in order to get through that trauma. There's very good evidence that drugs or medications with potential abuse factors, stimulants, benzodiazepines, can actually worsen the trauma response, not improve it.
Mm.
And the other big concern, quite frankly, is that for people who use substances, if you stop abruptly, you can have dangerous withdrawal, and somebody who's going through trauma may not have access to their usual supply. And so it can be really medically dangerous for somebody who has a substance use disorder to be in a traumatic exposure because they may be not only psychologically at risk, but physically at risk.
Yeah, I think it's interesting that if you don't think you have a substance use issue, you might see it be unmasked during these times because you don't have direct access to whatever you're using, alcohol or weed or whatever. You can't get it right now. So you're feeling this irritability and frustration that's unusual. It can unmask underlying substance use issues, and it can also exacerbate because of the stress of having to deal with all the financial consequences and all the day-to-day logistics. Now that your home is burnt down or your car has burnt down, that can exacerbate the use. You might turn to alcohol more to cope. So I think substance use is a big thing. We haven't honestly talked about this because people are still scrambling to deal with the immediate aftermath.
Yeah, absolutely. And a lot of the seminal work in disaster psychiatry and in this research was after Hurricane Katrina, when one of the biggest needs turned out to be substance use treatment, not even necessarily psychotherapy, because a lot of the substance use that maybe had gone undetected or was underground became really unmasked. Another big lesson that we learned from Hurricane Katrina and from the research after that is one thought used to be that if somebody goes through a trauma, what you really want to do is get in early and help them process that and help them understand it. And so talk about it and vent about it and really get into the trauma and do some of that work. What we now know is that the constant discussion of the trauma actually re-exposes the person to the trauma as they're asked or forced to continually recall it. So if you think about it, the medical model is the absolute worst place for someone to be after a trauma, because on the way into the emergency room, you'll talk to 15 people. And the first question of all of those people will be, what happened to you? And you have to recall it over and over and over again. So actually giving someone a little bit of space and not necessarily going in depth into tell me how you're feeling, tell me what happened, can actually be therapeutic. It feels strange, I think, even as psychiatrists, as mental health professionals, it feels weird to say, well, don't talk about it. But really avoiding re-exposing things can actually be a therapeutic intervention. And choosing distraction or choosing to talk about more pleasurable activities can be something that can actually be helpful to the person. You're not avoiding it. You're actually giving someone a little space from that trauma. The long-term needs of someone who's been through trauma include more psychosocial supports and building up someone's resiliency, preventing all of those risk factors that I just talked about. So if, goodness forbid, something else traumatic happens, you have a resiliency around it. That's what you're doing. You're almost trying to build that resiliency that may or may not happen naturally. So if someone breaks a bone, and you let it heal in the initial stages of healing. I'm not going to nerd out, but there's a difference between laminar bone and the early stages of bone, which is weaker versus fully developed bone. But if you take someone who broke their arm and replace it with titanium, right? If you turn them into the $6 million person, then they're going to be more resilient if they get hit in that same spot again. And that's really what therapy is designed to do. It's designed to build resiliency, work with somebody's natural mental healing factors to make them stronger in case, goodness forbid, something like this happens again. So that's really the goal of long-term trauma treatment.
Yeah. And this might be helpful for trainees and also families, but the way I ask this is actually to start with, you can tell me whatever you want or don't want to. You can take control of how this conversation goes. And I think that is really helpful. And oftentimes you'll get more than what you think you would if you start out that way, because it gives them that autonomy and that sense of control that they've completely lost with this disaster. And so if you go in saying, I'm going to ask the questions, you don't have to answer all of them. And if you want to stop, you can stop at any time. So when you are talking to someone who has been through this, it's really helpful to make it explicit that they have the floor and they can control the conversation.
Absolutely. And our roles are different and flexible as psychiatrists, but sometimes we'll see someone and do everything. Sometimes we'll see someone mostly for medications and talk about referring them to therapy. I've had multiple patients say, I don't want to go to therapy. And eventually you find out, because I don't want to have to talk about it. I don't want to have to go in detail into that, whatever it is, again. So explaining that that's actually not what trauma therapy is necessarily. Now, also for trainees, you may be sitting there frustrated and thinking, you're missing a huge piece. And trainees, you are correct. So let me explain myself a little bit. Going back to the idea of the medical model, if someone's been through a trauma, let's say it's a physical trauma. Someone comes in and someone has a huge cut on their arm, right? They come into the emergency room. What you do initially is just clean it up. You rinse it up, you bandage it up. You actually don't do that much. You support the body in the natural healing process. Now, if during the process of that healing, someone develops an abscess, then you have to get much more invasive. You may have to take them to the emergency room. You have to cut it back open, drain it, pack it. You have to do a lot more intervening work and really focusing on it. Actually, mental health trauma is not dissimilar. So if somebody has been through a big trauma, traumatic response, what you want to do is support them in their natural healing response. And the framework for that, that I'm most familiar with, is called psychological first aid, PSA. Essentially, it's not going in depth into the trauma itself. It's supporting coping skills, de-escalation, ways to reduce your own autonomic activation, your stress response, to lean into your strengths, to lean into your connections. It's not about that intensive debriefing. If through that process, someone does develop acute stress disorder or post-traumatic stress disorder, then the focus shifts, sort of like an abscess. Then you do cognitive processing therapy or even prolonged exposure, which is in the name. And in that case, you actually do go very in-depth into the trauma in a very structured, controlled setting in order to uncouple the memories of those traumatic experiences from the emotional response that happens. That's a very particular intervention, and I myself don't do that. I refer to experts, people who just focus on that and do that, because it can be a fine line of how to do that well and help someone recover without re-exposing them to the trauma that they're going through. But that's really the distinction, is that in the initial phases, you do want to be more supportive, not go in depth into the trauma, very respectful of what somebody does or doesn't want to talk about, and work on building up strengths. But if there are signs that the trauma is becoming more entrenched, then you do have to go in and pull it out.
Exactly. And oftentimes you meet people who have gone through like unimaginable things. Maybe they had to jump out of an airplane, or they had to survive in the woods for a week because they got kidnapped. And they don't exhibit symptoms of PTSD. They actually go through therapy, they cope with it, and then they move on with their lives. They have moments, but they're doing okay. And then you have people who have a really dramatic response to a traumatic event, and they ruminate. They can't get it out of their head. There's a lot of anticipatory anxiety, like this could happen, that could happen, and it debilitates them. So the way that you try to look for the difference is really the support system. How much support system they have. And it doesn't have to be necessarily family or friends. It could be if you have a therapist, a provider, a PCP, a family physician, or I don't know, a bowling club, some sort of community system that can take this path of healing with you. That is so, so important because the worst parts of PTSD manifest when you feel alone, when you are absolutely alone in this journey. I wanted to point that out because I think sometimes we assume PTSD from the traumatic event, but it's not always that way. It's really about how hopeless and lonely you feel in that space.
I think that is completely true. That's one of the most important things. Humans are social animals. Even the most introverted, the most anxious person still relies on other people and other support systems. No one's an island. And it's not to say that there's anything wrong with introversion or great about extroversion, but I mean, we have mirror neurons. We have literal neurons in our brain, structures that are designed to mimic people that we see. We are social animals. There's no way not to say that.
Yeah, absolutely. And I guess speaking of social interaction, in the psychological first aid, I noticed that that's a big theme, is to communicate, to have an empathic ear and listen. But also if they're not feeling like talking, right? Because this is, I think, something we come across a lot. So I'll be talking to parents and talking through, like, how would you talk to your kid about this and that? And they would be like, yeah, they spent like 5 minutes with me and then they wanted ice cream. They're on to the next thing, just moving right along. And I think that's also an important part of exactly what psychological first aid is saying, is that you can't immerse yourself in this, especially in the immediate aftermath, because it's too much. You need a mental break from talking about it. So whatever the flow of the conversation goes, it's important to follow that because it, again, gives them that sense of autonomy and independence back.
Yeah. And I think the goal is not to make people anxious about it, especially parents or caregivers. It's, oh, when do I talk? When do I not? Should I ask them more about this? Should I not ask them more about this? What is the right thing to do? Right? It's in the title of the podcast. You got to be good enough and learn to follow the person's lead in ways, sometimes verbal, sometimes nonverbal. Let them direct the flow of the conversation. Sometimes they'll be curious. They'll want to talk more about it. And sometimes even in the middle of a discussion, it'll get to be too much. And the way that'll come out is, let's go get pizza, or I don't want to do this. And that's totally fine. You don't have to redirect. You don't have to encourage them to stick with it. You can take a break. And people do, sometimes consciously, sometimes unconsciously, figure out when things are a little bit too much, and there is a natural healing process. I think that's one of the big reasons for the distinctions that we're trying to bring up, is that, as you said, some people are just fine and very resilient after a trauma. And actually, after a traumatic exposure, I believe about 20% of people, it depends on the exposure, will go on to have symptoms of acute stress disorder. So 80% do not. They'll have a quote unquote normal. They'll have an average response to the trauma, but not go on to develop the either severe or persistent symptoms. And from acute stress disorder to post-traumatic stress disorder, again, depending on multiple factors, anywhere from 50 to 80% will progress to PTSD if they get no treatment at all. So about half in some studies, the acute stress disorder will just disappear without ever receiving any sort of treatment. So there's still an ongoing process of healing that happens naturally. Now, that's not to say that it can't be easier. That's not to say that seeing a therapist, psychiatrist who's skilled at these sort of evaluations and can pivot and do both psychological first aid and more in-depth trauma treatment is not a good idea. It does increase the likelihood that someone will recover, but some people are just fine and they're allowed to be just fine.
Right. So maybe it's helpful to highlight some of the concerning symptoms for families and parents. So when a kid or anybody is having this persistent preoccupation with the disaster, intrusive thoughts, I think we all had some level of this, but as the fire was spreading, I was watching Watch Duty, the website to monitor the fires. every 10 minutes I was refreshing. So
Sure.
that is normal when it's happening. But if it's persisting 3-4 weeks later, you're still doing that with the fear of any fire can start from a home barbecue up in the hills. And so I got to watch this website and keep an eye on the fire. That is concerning. And sleep disturbances that are persistent. Again, nightmares and disturbed sleep in the first couple of weeks is normal. However, if it persists for more than that, for more than a month, definitely concerning. And then turning, like we said, to substances like alcohol and drugs and withdrawing from family and friends, or just any significant change in your behavior or emotional state. Anything that you're like, well, this is not me. I know this is not me. That's something that raises concerns, and that's when you want to seek professional help.
Yeah, I absolutely agree. I think it's never wrong to seek an assessment. That is one thing I will say. If you're second guessing, if you're considering it, I would almost always encourage to just go ahead, find someone you trust, get a good recommendation from your pediatrician, from someone who's a reliable source, and get an assessment. You're never going to go wrong with that. But I think there are certainly some signs that make it more important to get that assessment done, or lend more of a professional and to some extent independent eye to what's going on.
Mm-hmm. Oh, that's a really great point. Yeah. So maybe just going through some of the practical advice to wrap this up so that we can leave you with something to use today. So I think first and foremost is creating a supportive environment that fosters open communication. I cannot stress this enough. I think we've said this so many times on this podcast, but kids know. Kids see everything. They just know. They can feel it. They can sense it. Their antennas are very sensitive. And so if you think they might know, they definitely know. If you're like 50-50, they most likely also know, you know? And so there's inevitably a lot of questions that come up. And sometimes we are frankly afraid of telling kids the honest answer, which is oftentimes, I don't know. I don't know what's going to happen. Am I going to school next week? Are we going to have a house to stay in next week? Am I going to be able to eat my favorite dessert tonight? I don't know. I don't know. And I think it's important to emphasize that there's nothing wrong with saying, I don't know. And following that with, one, validating their feelings about the frustration of not knowing something. And then second, it's important to say, and we're going to figure it out.
Absolutely. I can't emphasize that enough. I think that's so important. And everyone wants to be the person with the answers, the protector, the one who's taking care of the situation, and you don't want to expose that uncertainty. Then sure, for a child, it's fantastic to see their parent as the rock, as the solid person who will deal with anything that comes up and knows what to do. It is also extremely useful and good modeling to show that sometimes you don't have the answer and you don't know what it is, but you can figure it out together as a unit, as a family, can stay safe and can make this work even in uncertain times. That's such a useful skill. And I think sometimes we actually kind of rob kids of that by trying to be too certain about everything.
Exactly. Yeah. It's almost like if you are this perfect parent that can handle everything, there's no room for mistakes, for the kid to try and fail and rise up again. And that's the essence of childhood, this is of the essence of learning. And so absolutely what you're saying about being able to solve these problems together and validate each other's distress is really important. And so in that validation, another question that comes up is, can I cry in front of my kid? Or can I show them that I'm having a mental breakdown, or do I have to hide it? Now, you have to be careful, because you certainly don't want to have your child feel like they are the caretaker. I think that's a tricky place. So you kind of have to collect yourself on your own. This is universal. It doesn't matter if you're a parent or a partner or a friend or a sibling, whatever. You have to do some level of your own work before you can go to another person. So again, self-care is really important. But the question of crying, expressing that really sad or negative emotion in front of your kid, it always comes back to just honesty.
Hmm.
The truth and the honesty, the act itself is not really the problem. The problem is that there's no communication about it afterwards. So you're crying and your kid is seeing you cry, and then there's no discussion whatsoever of what has happened. So there's no repair of that disruption and that secure attachment. And so then what's important is that once you've settled and collected and you did whatever you needed to do, going back and saying, Mom and Dad are really upset and sad. It's been so hard. And how did you feel when you saw that, when you noticed that? And then wrapping it up with, we're going to figure this out together. I think that conversation is so important to have. And a lot of us are so scared to talk about that. It's like the whole suicide conversation, right? Like if you don't talk about suicide with your kid, they're not going to think about it. That's not how it works. There's so much information out there that you can't protect your child from information. You have to give them the tools to cope with whatever they're going through. And so having that conversation to repair whatever disruption they had is really critical in this motto of fostering open communication.
Absolutely. And I think it teaches kids that you can have strong feelings that are not an emergency and that are not in control, and that feelings are not something to be afraid of. Feelings are not something that need to be fixed or squashed or moved, that you can feel scared and worried and upset and also in the moment safe. And it actually adds a richness to the child's internal emotional life. That's part of the development of getting out of that black and white thinking and learning to appreciate the grays, and that life is complex. And, I'm smiling because Inside Out was pretty good about that. You
Oh,
can't just
yes.
have one colored feeling ball. Sometimes you have balls with multiple colors, and that you can be happy and sad at the same time. And feelings can be complex, but they don't necessarily need to stop or be repaired in a way.
Mm-hmm. Yeah. Yeah. Great movie. Non-sponsored promotion, of
Yeah,
course,
right.
here. Yeah. No, we don't get any money from anybody here. But yeah, the movie really captured the ability to hold multiple emotions, and that's fine to have. It's the same thing with adults. So being able to like recognize that and take time for yourself and self-care, I know that also comes with privilege. I think a lot of people don't have the opportunity to do that. But I think even if you can take 10 minutes to just sit there and do nothing, 15 minutes to meditate, close your eyes, take deep breaths, I think that's so helpful because we're working with a nervous system that's freaking out. So you really need a moment to decompress and be with yourself and notice what's happening in your body and then let go. So there's very much practical, easy ways that you can self-care in the here and now.
Yeah, without overthinking it, with just taking a little bit of time, it can be the most helpful thing to do. And actually, it's when you think you have the least amount of time that it's the most important to do that.
Yes, it's so true. That is so true. Yeah. Everything looks different after you take a few moments of pause.
So we will have some additional resources in show notes. There are many, many different guides and tools. One thing that we didn't mention is that a lot of times when your brain is in a stress response, it's not great at taking in new information because it's so full of processing what's going on right now. So for parents, for kids, you may have to repeat yourself. You may get the same question 100 times, and it is okay to just give the exact same answer the same way. It's not denial. It's not repression. It's simply that the information either didn't go in or didn't go in a way that's reaccessible at this time. So you just keep repeating, and you don't get frustrated, and you just say the same thing. Are we going to be okay? We're going to be okay.
Right. Yeah. Repetition is key. So hopefully this has been helpful. These are some of the questions that we get in our work, but certainly not everybody can go see a child psychiatrist. I understand that. So if people want to submit their questions, we'd be so happy to answer them.